Hi everyone. So today I'm going to be talking about a very important class of drugs, especially in anesthesia, which are the neuromuscular blocking drugs. These form a vital part of modern anesthetic practice. They form part of balanced anesthesia, along with analgesia, unconsciousness, abolition of reflexes, skeletal muscle relaxation, which is provided by neuromuscular blocking drugs, is an integral part of balanced anesthesia. Neuromuscular blockers have been integrated now into most anesthetic techniques for major surgery, and they naturally have become key components in the safe anesthetic practice and also the development of advanced surgical technique. In fact, neuromuscular blockers not only revolutionized the practice of anesthesia, but they also started the modern era of surgery. And without neuromuscular blocking drugs, advanced specialties of surgery such as cardiothoracic surgery, neurosurgery, organ transplantation surgery would not have been possible. So, studying neuromuscular blocking drugs, understanding their pharmacology, how they work, what are the various pharmacodynamic effects, clinical uses, side effects, is very important for an anesthesiologist to understand. So you should have full mastery over the various neuromuscular blocking drugs. The first neuromuscular blocking drug that was discovered was DTC, or tubocurarine. Tubocurarine was a naturally occurring alkaloid, and it was actually being used for hundreds of years, if not more than that, by the native people of the Amazon. And this actually can be isolated from an Amazonian vine called Condodendron tomentosum. That was the name of the plant from which D-tubocurarine was isolated. So what these people, native people of the Amazon, used to do, they used to burn the bark of that plant. And the bark had very high concentrations of a poison known as curare. And D-tubocurarine is actually the one type of curare poison. There are others also, but tubocurarine was the poison, curare poison, which was present in the plant Condodendron tomentosum. So they used to burn the bark of this plant, and they used to dip their arrowheads and other hunting equipments in that burnt ash thing. So then they used to use those arrowheads as part of their hunting tools, and that used to cause asphyxiation in the animal because of respiratory paralysis. So, D-tubocurarine was essentially discovered in 1942, but at that time there were no safety guidelines that had been established. There was relatively deficient knowledge of the pharmacology of neuromuscular blocking drugs. The concept of residual neuromuscular paralysis in the post-operative period was not much understood. It was not well established. There was no concept of reversing the effects of neuromuscular blocking drugs by using drugs such as neostigmine and anticholinesterases. So that is why, because of the general gap of knowledge in the pharmacology of neuromuscular blocking drugs, there was a very high increase in mortality in patients who were being given tubocurarine for surgical muscle relaxation. But later on, as people and anesthesiologists and surgeons got to know more about the pharmacology of these drugs, better drugs were developed, such as choline was introduced in 1950s, I think. Right, it was described in 1950s. Then in 1967, you had the development of first steroid, which was pancuronium. Then in the 1980s, you had the development of atracurium, vecuronium, right? And in the 1990s, there was the development of mivacurium, which was the first short-acting neuromuscular blocker. Rocuronium was also developed. Right. And throughout the years, there have been so many others that are not in clinical use anymore. For example, rapacuronium was developed, but it had to be withdrawn from the market because it caused severe bronchospasm. Right. Then cisatracurium was developed, but it is still being used today. Doxocurium was developed. There was pipecuronium that was developed. And there are certain drugs that are still under investigation, such as CW002, CW175950. These are still under investigation. Right. So before we talk about the pharmacology of these drugs, briefly want to go over the physiology of the cholinergic system. So as we all know, this diagram represents the neuromuscular junction. This is the presynaptic membrane, the postsynaptic membrane. Within the presynaptic nerve membrane, nerve ending, we have the formation of acetylcholine from choline, which is derived from serine. It combines with acetyl coenzyme A and forms acetylcholine, which is then packed into these synaptic vesicles. With the increase in intracellular calcium due to the incoming action potential, the synaptic vesicles fuse with the presynaptic membrane and release acetylcholine in the form of quanta. Each quantum of acetylcholine contains 10 raised to power 4 molecules of acetylcholine, and each vesicle normally releases only one quantum of acetylcholine into the synaptic cleft, from where they interact with the postsynaptic receptors. Now, postsynaptic receptors cholinergic receptors can be of two types. We have nicotinic receptors and we have muscarinic receptors. So, cholinergic receptors can be divided into muscarinic receptors and nicotinic receptors. So, muscarinic receptors, for our purposes of discussion, nicotinic receptors are more important because these are the receptors with which neuromuscular blocking drugs are going to interact with. Muscarinic receptors are G protein coupled receptors. I'm sure you all know the various types of receptors that are there. So G protein coupled receptors, they can be GS protein coupled receptor, GI protein coupled receptors, or GQ protein coupled receptors. They act by increasing or decreasing cyclic AMP activity, or in case of GQ, they act by inositol triphosphate diacyl glycerol pathway, thereby increasing or decreasing intracellular calcium and leading to activation or deactivation, phosphorylation of various proteins and producing their respective physiological effect. So we have M1, M2, M3, M4, M5 receptors. M1 receptors are principally present in the gastric epithelium. M2 receptors are present in the heart. M3 receptors are present in the smooth muscle, such as bronchial smooth muscle, vascular smooth muscle, gut smooth muscle, bladder smooth muscle, etc. M4, M5 are usually present in the central nervous system. But this is not a hard and fast rule. For example, M1 and M2 receptors are also located prejunctionally, right? Or they are also present on the presynaptic membrane. And they cause modulation of acetylcholine release. So how much acetylcholine is being released with each action potential? We know that with the incoming action potential, acetylcholine is going to be released, but how much of it is to be released? If there is very, very high in frequency of action potential coming into the synaptic cleft or the neuromuscular junction, what should be the release of acetylcholine? Should it be more? Should it be less? So that modulation is done by presynaptic receptors. Some of them are of muscarinic type. Then the nicotinic receptors are also of two types. We have NM receptors and NN receptors. So NM receptors are naturally located at the neuromuscular junction, whereas the NN receptors are located in the autonomic ganglia and also in the central nervous system. Right? So just like muscarinic receptors were G protein coupled receptors, nicotinic receptors are ligand gated ion channels. So essentially what it means is, if this is your phospholipid bilayer, this is your ion channel. So this ion channel will only open when a specific ligand will bind to its site on this receptor, then only the ions will be allowed to pass. So that is what it's meant by ligand gated ion channels. Similarly, you have other types of ion channels, such as there are voltage gated ion channels as well, that open when there is a change in the resting membrane potential, or in other words, depolarization. So depolarization is going to open the voltage gated ion channels. But nicotinic acetylcholine receptors are ligand gated ion channels. Now, nicotinic acetylcholine receptors are described to be pentameric, which means that they are composed of 5 subunits. So 4 of the subunits are going to be common in the 2 different types of nicotinic acetylcholine receptors that we are going to talk about. We have the mature receptors, and we are also going to have the immature receptors. Immature receptors are also known as the fetal type of receptors, which are also known as the extrajunctional type of receptors, whereas mature receptors are also known as the adult type of nicotinic acetylcholine receptors. The mature type of nicotinic acetylcholine receptors are going to have 2 alpha subunits, 1 beta subunit, 1 delta subunit, and 1 epsilon subunit. So stoichiometrically, you can represent the mature nicotinic acetylcholine receptors as alpha 2, beta, delta, epsilon. But organizationally, you can represent it as alpha, epsilon, alpha, delta, and then beta. And that is because if this is the lipid bilayer, the nicotinic acetylcholine receptor is going to be arranged as follows. So this is the alpha subunit. Then you have the epsilon subunit. Then you will have, you will have another alpha subunit. Then you will have the delta subunit. And finally over there you have the beta subunit. So this is alpha, epsilon, alpha, delta, and beta. So organizationally, you can represent the mature receptor as follows, correct? Whereas the immature receptor is going to have 2 alpha subunits, 1 beta subunit, 1 delta subunit, and instead of this epsilon subunit, it is going to have the gamma subunit. Now the basic difference between the two is that the mature or adult type is going to have a shorter opening time, but it is going to have a much higher conductance for sodium, potassium, and calcium. Whereas the immature type is going to have longer opening times. It is going to keep the sodium channel open or ion channels open for a longer period of time, but it is going to have a lower conductance. Another thing is that the mature or adult type is going to be concentrated at the neuromuscular junction, where the muscle membrane meets the neuronal membrane. Here the density of the adult type will be maximum, whereas the fetal or immature type is going to be present all over the muscle fiber, irrespective whether it is the neuromuscular junction or the or rest of the surface. So it is going to be present diffusely everywhere. And naturally, this type of receptor is more commonly seen in fetuses and neonates, and that is why it is known as the fetal type of acetylcholine receptor. Right? So the neuromuscular junction also, if you talk about the arrangement, the postsynaptic muscle membrane is actually thrown into various folds such as this. This effectively increases the surface area, right? Now each of these folds is going to have a crest, and it also has a trough. The crest is going to be rich in nicotinic acetylcholine receptors, right? So it has a density of around 10,000 to 30,000 receptors per micrometer cube, square. And the troughs are going to have voltage gated ion channels. So naturally, as the action potential comes in, it is going to cause the release of acetylcholine into the synaptic cleft, which will interact with the nicotinic receptors which are found on the crests, which will cause sodium to enter into the muscle membrane, which will destabilize the resting membrane potential, causing action potentials to be generated and voltage gated sodium channels to be opened, which will cause more sodium to enter the muscle cell, which will cause more depolarization in the adjacent muscle membrane, thus opening even more sodium channels, voltage gated sodium channels, and in this way the depolarization wave will progress throughout the sarcolemma or the muscle membrane. And then I'm sure you all know the basics of muscle contraction. The depolarization wave is going to travel into the T tubules. Then you will have opening of various calcium channels. There is rhinodine receptors, which are going to cause even more release of calcium from the sarcoplasmic reticulum. There will be excitation contraction coupling, the sliding filament model of actin and myosin, and eventually the contraction of the muscle fiber or the muscle cell. So that is how the normal excitation contraction occurs. Another point of distinction or differentiation should be there are two different types of, or rather, on the basis of affinity. I'm sorry, I forgot to mention the various sites of acetylcholine binding. Now, each molecule of, or sorry, each receptor, the nicotinic acetylcholine receptor, is going to have two binding sites for acetylcholine. So, if you take a look at this diagram, this whole thing represents one alpha subunit, just one out of the 5 subunits in the whole receptor. This just represents one alpha subunit. Now naturally this is a protein, so it is going to have an N terminus and a C terminus, and it is also going to have these 4 domains which are labeled from M1 to M4. Please do not confuse them for muscarinic receptors. These labels are for the domains of the alpha subunit. Now, the M2 subunit is the subunit which is going to line the pore or the inner pore channel of the ion channel. So, M2 domain of each of the subunits is going to line the inner side of the ion channel. So the free N terminus of the alpha subunit and the epsilon subunit, as you can see, these long thread-like structures, one is coming from the alpha subunit, the other from the epsilon subunit. So the N terminus of the alpha and the epsilon subunit is going to form one binding site to the acetylcholine, and this is known as alpha H epsilon. H here stands for high affinity. And the free N terminus of the other alpha subunit and the delta subunit will form the other binding site for the acetylcholine, which is labeled as alpha L delta. And here L stands for low affinity. So high affinity and low affinity, but with respect to what? So this high affinity and low affinity was actually described with respect to tubocurarine. Right? It was found that tubocurarine had 100 to 500 times more affinity for the alpha epsilon site than for alpha delta site, and that is why these different nomenclatures were given. Right? So that is how the post-junctional receptors work. I would also like to quickly talk about the structure of acetylcholine. So this is the structure of acetylcholine. Now the important thing to focus here is the presence of this quaternary nitrogen atom. This is called a quaternary nitrogen atom. Now we know that the valency of nitrogen is 3. So that means nitrogen can only form 3 covalent bonds. If it is forced to form a 4th bond, it has to sacrifice its electron. If it loses an electron, it acquires a positive charge. Right? And the presence of this positive charge is a critical feature of acetylcholine molecule. And virtually all neuromuscular blocking drugs are going to have this quaternarized nitrogen atom, and that confers a structural similarity between the various neuromuscular blocking drugs and acetylcholine. And that allows these drugs to actually interact with the nicotinic acetylcholine receptors. Now, succinylcholine, if you take a look here, is nothing but it is 2 molecules of acetylcholine joined together by an acetate methyl linkage. And that is why succinylcholine, which is often sometimes just called as choline, acts as an agonist at the nicotinic acetylcholine receptors. So it produces the same effect as acetylcholine because of such high structural similarity. But naturally it binds to these receptors for a much longer time than acetylcholine, which is the natural ligand. Non-depolarizers, on the other hand, for example, VEC, ATRA, ROC, etc., they also have this quaternary ammonium nitrogen atom, but they are very, very bulky. And because of that, they do bind to the nicotinic acetylcholine receptor, but they cannot activate it. And therefore, they just go bind to it and then prevent acetylcholine from binding to it, and therefore they act as competitive antagonists at these receptors. Right. Now, we talked about the post-junctional effect of nicotinic acetylcholine receptors, but what about the pre-junctional effects? So, like I said, there are going to be post-junctional nicotinic acetylcholine receptors. But there are also going to, and they can be either alpha to beta delta epsilon or alpha to beta delta gamma. So this is the mature one and this is the fetal one. But they can also be present pre-junctionally. Now pre-junctionally, they can be alpha 3 beta 2 or alpha 3 beta 4. So they here also they are pentameric only, but they do not have these delta epsilon or delta gamma subunits. But what is the function of these pre-junctional nicotinic receptors? They cause modulation of, or they regulate the, or modulate the release of acetylcholine, especially in situations where there is an increased firing frequency. The activation of these alpha 3 beta 2 pre-junctional receptors will cause acetylcholine vesicles essentially to get mobilized. So acetylcholine is stored within the vesicles in the synaptic endings. Now there are two types of population of these vesicles. One is the readily available one. So as soon as the action potential comes, these readily available vesicles are going to degranulate and release the acetylcholine in the synaptic cleft. But there is another population that has to be mobilized. So they're not readily available, but they have to be mobilized. So when do they get mobilized? As the firing frequency increases, more and more acetylcholine is released. As the acetylcholine is released, it not only interacts with these postsynaptic nicotinic receptors, it is also going to interact with these presynaptic acetylcholine receptors. And this causes mobilization of these acetylcholine vesicles into the more readily available form. And that allows more and more acetylcholine to be available for discharge in order to keep up with the increased firing frequency. So that is how modulation works. Another very important thing to be kept in mind is that these very same receptors, the alpha 3 beta 2 receptors, are involved in fade phenomena, which we will talk about later when we talk about neuromonitoring and residual neuromuscular paralysis. What we mean by fade phenomena. Essentially what we mean is that if you give a tetanic stimulation, let us suppose this is a nerve, and you give an electrical stimulation to the nerve from outside. Now this nerve is going to supply the muscle fibers. So if you give tetanic stimulation, that means if you repeatedly stimulate the nerve at a frequency of 50 to 100 hertz, so here you are stimulating this, this is the stimulus, and then you are measuring the response. So if you see that with each successive response, the amplitude keeps on decreasing, this is known as fade. Correct? But this should, in normal circumstances, this should not be there, right? So in normal circumstances, if you provide a tetanic stimulation, the response should be there should be no fade. The amplitude of contractions should not decrease. Why? Because as the firing frequency increases, for example, as in tetanic stimulation, because of the activation of these presynaptic receptors, more and more acetylcholine will be available for release, and therefore more and more receptors will be incorporated or activated, and the strength of contraction will be maintained. But if you give a drug which blocks nicotinic acetylcholine receptors, for example, non-depolarizing muscle relaxants such as atracurium, it blocks nicotinic acetylcholine receptors, not just the postsynaptic ones. We know that atracurium is going to block these receptors, but it also blocks these presynaptic ones. So if it has blocked, atracurium has blocked the presynaptic receptor, then in response to increased firing frequency, this mobilization of acetylcholine vesicles will not be able to take place, and more acetylcholine will not be available for release. And this will lead to subsequent decreases in the contraction of the muscle, which will be seen as a fade phenomena on neuromonitoring, neuromuscular monitoring, either by EMG or MMG or AMG or KMG. We will talk about all of these in a subsequent lecture on neuromuscular monitoring. Right, so fade phenomena is also mediated by these receptors. And a very peculiar thing to note is that succinylcholine has no affinity for these alpha 3 beta 2 pre-junctional receptors. So if succinylcholine does not interact with these receptors, then on technic stimulation, it will not block the pre-junctional receptor, and therefore this mobilization is going to take place, and more acetylcholine will be able to be released, and therefore the response to technic stimulation will be maintained, and therefore no fade will be seen with succinylcholine. So that is why you will not see succinylcholine, fade with succinylcholine, and you will see fade with non-depolarizing muscle relaxant, because fade is mediated by these pre-junctional receptors. However, if you start to see fade phenomena with choline, or if you start to see post-technic potentiation, then that means you have entered a phase 2 block, which is not a good thing. Right? So phase 2 block is a pattern which you see on the neuromuscular monitoring when the block produced by succinylcholine starts to resemble the block which is produced by a non-depolarizing type of muscle relaxant, such as fade and post-technic potentiation. So this is one type of pre-junctional receptor, the nicotinic receptor. But you also have other types, which are the muscarinic types. Muscarinic types of pre-junctional receptors. Now they are M1 receptors and M2 receptors. Now M1 receptor actually creates a positive feedback, wherein activation of M1 receptors is going to lead to increase in intracellular calcium because of increased calcium influx into the nerve ending, which will cause increased acetylcholine release. Whereas M2 will create a negative feedback and will cause a decrease in acetylcholine release. Right? So you should also be aware of not just the post-junctional receptors that are involved in neuromuscular physiology, but also the pre-junctional. Now, in the next part, we are going to talk about succinylcholine in detail. Its pharmacokinetics, dynamics, its onset, what do we mean by ED95, what are the indications of succinylcholine use, what are the side effects that are associated with succinylcholine. And then in subsequent lectures, we will discuss the non-depolarizing type of muscle relaxants. And finally, we will also then talk about various reversal agents as well. So in the next lecture, we are going to talk about succinylcholine.